Welcome to Pomegranate Case Reports, another podcast format generated by members of the Royal Australasian College of Physicians. I'm Mick Cavazzini, but for this episode, I'm going to hand the reins over to Dr. Stephen Bacchi. He's a neurology registrar at the Lyell McEwin Hospital and a Fulbright scholar, and I recruited him to the podcast editorial group after he peppered me with lots of ideas and feedback last year. It was Stephen's suggestion to present some case reports that could be educational for trainees in particular. Today's example comes from the Royal Adelaide Hospital, and you'll find a link in the show notes to the full story at the Journal of Neuro-Ophthalmology. But perhaps you can test yourself first as you listen to two of its authors drip-feed findings from the patient's history and examination. I hope you learned something, and maybe even feel inspired to submit a case report yourself in future. Over to Dr. Bacchi.
Thanks for joining us. So, with me today, I've got Dr. Sumu Simon, who's a fellow of the Royal Australian New Zealand College of Ophthalmologists. She completed a Master's in Ophthalmology from Christian Medical College for Law, India. She became a fellow at FRANZCO in 2012, and she's a general ophthalmologist with special interest in neuro-ophthalmology, adult strabismus, adult squint surgery, medical retina, cataract, and glaucoma. And from a physician side of things, I've got Dr. Brandon Stretton, who's a basic physician trainee with an interest in perioperative medicine and evidence-based medicine on the whole. Thank you very much for joining us.
Thank you for having us, Stephen.
So today we'll be going through a case and going through some questions that are relevant to a generalist audience and also trainees. So to start off with, we have a 68-year-old man. He's presented to the emergency department. He's got a history of type 2 diabetes mellitus, and he's presented with sudden onset monocular vision loss in the right eye for several hours. Dr. Simon, could you please talk us through the types of differentials you'd be considering at this stage?
So we are dealing here with acute onset unilateral visual loss in a 68-year-old gentleman with known vascular risk factors, right? So I would take a more detailed history in order to know more about the visual loss, because that is quite helpful in determining what the underlying cause for the visual loss could be. So I want to know whether the unilateral nature of the vision loss was confirmed by occluding one eye at a time. I want to know more about the severity of visual loss and whether the visual loss is stable, progressive, or improving. I also want to find out whether the vision loss was associated with pain or not. It is important to ask the patient whether the vision loss is central. So central vision loss could be seen in optic neuropathy or macular-related vision loss, whereas if it's more generalized, it is likely to be related to an optic nerve or retinal problem. You also want to know whether it's affecting just a portion of the field of vision. So I also want to know about other associated ocular symptoms like transient monocular vision loss, redness, flashing lights, and double vision. I would inquire about neurologic and systemic symptoms, including headache, jaw claudication, and scalp tenderness. It is also important to ask for a history of trauma and to go through the medical diagnosis, past medical history, and medications, as all this could provide valuable clues to the underlying etiology. So our patient has presented with unilateral and sudden vision loss. So the localization of the vision loss is to the prechiasmal region, and it could be anywhere between the cornea and the prechiasmal optic nerve. Considering the patient's age and the fact that he has known vasculopathic risk factors, the differential diagnosis for sudden vision loss in this patient will include optic neuropathy. It could be from vitreoretinal causes like a vitreous hemorrhage, retinal detachment, retinal vascular occlusions, or wet age-related macular degeneration. Uveitis and corneal oedema can also present with a sudden vision loss in this age group.
Thank you. So how would your approach to painless vision loss differ from vision loss with pain?
Okay, so it is important to find out whether the patient had a painless or painful vision loss. This helps me to narrow the differential diagnosis. The vision loss is painless in retinal vascular occlusions, non-arthritic anterior ischemic optic neuropathy, compressive optic neuropathy, as well as in a number of vitreoretinal condition causing vision loss, such as vitreous hemorrhage, wet macular degeneration, and retinal detachment. Vision loss associated with pain, on the other hand, is most often indicative of an underlying inflammatory cause, but it can also be due to an infectious or infiltrative cause. Painful vision loss can also be due to raised intraocular pressure, for example, in a patient with acute angle closure glaucoma. Be also aware that pain on eye movements associated with vision loss is most often seen in patients presenting with optic neuritis related vision loss.
And Dr. Simon, how about if there was an altitudinal visual field loss?
So, altitudinal visual loss tells us that the patient is missing either the superior or inferior half of the peripheral field of vision. The presence of an altitudinal field loss does not point to a specific diagnosis. It can be seen in patients with optic neuropathy, but can also be seen in patients with retinal vascular occlusions. For example, hemiretinal artery occlusion, hemiretinal vein occlusion can present with an altitudinal visual field loss. Sometimes patients with retinal detachment can present with altitudinal visual field loss as well.
Well, that's very helpful. That gives us a framework to approach this patient. With additional history taking, the patient discloses that the night before their presentation, they in fact had preceding ipsilateral 10 minutes of vision loss. So the same eye had 10 minutes of vision loss the night before. So Dr. Simon, could you outline how that affects your thought processes and how you describe this phenomenon? And then Brendan, I'd be interested in your thoughts as well.
So the history of preceding ipsilateral monocular vision loss lasting for 10 minutes is very important. This visual symptom is suggestive of emerosus fugax. Emerosus fugax is transient monocular vision loss that occurs secondary to ischemia in the retina, choroid, or the optic nerve. It is a form of transient ischemic attack. So you can compare it to the TIA equivalent affecting the eye, and usually lasts from a few seconds to 30 minutes, and the visual loss is followed by a full visual recovery. Patients often describe this as blacking out of vision or a gray curtain that progresses from the periphery and moves towards the center of the vision. Emerosus fugax is a presenting symptom in 7 to 18% of patients with visual loss due to giant cell arteritis. So it is important to be aware that emerosus fugax can be the presenting symptom of GCA, and that it is an important predictor of permanent and visual loss in patients with giant cell arteritis. So emerosus fugax can be due to ocular ischemia from a significant carotid artery stenosis. It can be due to transient disruption of ocular circulation due to emboli from an arthromatous plaque in the internal carotid artery. But it can also be due to cardiac causes like atrial fibrillation or from plaques adherent to the valvular heart disorders. Patients with emerosus fugax need urgent evaluation as they are at high risk of irreversible visual loss, cerebrovascular accidents, and myocardial infarction. If you do an ocular examination in a patient with emerosus fugax, the clinical findings are often unremarkable. Patients with this symptom need prompt blood tests for inflammatory markers and assessment of vasculopathic risk factors. In addition to blood test, urgent carotid ultrasound, brain scan, ECG, and cardiac echo should also be organized.
And yeah, I don't have much to add to that. It was very comprehensive. I would just use the term transient monocular vision loss. However, the term amaurosis fugax is one that commonly gets thrown around in these settings. Amaurosis, actually the root word meaning to darken, to obscure, and fugax translating to transient or fleeting, if I recall correctly. So the term's often used to describe or depict episodes of sudden vision loss that are temporary and affect one eye. And the implication when you're using that term is that it's related to an interruption in the blood flow in the retina. So bearing in mind that the blood flow is supplied by the ophthalmic artery, which in turn is a branch of the internal carotid, pertinent considerations for someone with an amaurosis fugax would be like an atherosclerotic embolus, as Dr. Simon said, from the ipsilateral carotid artery stenosis, or something a bit further down, like a cardioembolism, which could be caused by atrial fibrillation or other valvulopathies, or maybe even a mural thrombus. So bearing that in mind, and particularly noting that Dr. Simon said we consider these as a TIA mimics, this is something we tend to consider as a harbinger for a stroke, and something we take very seriously with the extensive workup formerly mentioned, other causes of retinal ischemia being something to consider would be like a vasculitis, particularly a GCA.
Great, thanks. So on the whole, this is worrying, increases our concern, thinking about ischemia, thinking about carotid stenosis, cardioembolism, and giant cell arteritis, all things we're thinking about. So now with additional information, the patient discloses some more symptoms. They describe that they've had systemic symptoms of neck pain, temporal headache, and tenderness for 2 weeks before presentation. Their best corrected visual acuity was found to be hand movements in the right eye and 6/6 in the left eye. Examination shows a RAPD in the right eye with associated dyschromatopsia and a central retinal artery occlusion, or CRAO. So Dr. Simon, for the sake of discussion and learning, could you please explain to us what a RAPD is?
The systemic symptoms are highly suggestive. I'm concerned that this could be a giant cell arteritis-related central retinal artery occlusion at this stage. So a relative efferent pupillary defect is a critical test in a patient who presents with vision loss. Not only acute vision loss, but also patients who present with subacute or chronic visual loss. It is important to remember that normal individuals have bilateral and equal innervation of pupils. RAPD is helpful in eliciting a defect in the pupil pathway on the efferent side. RAPD is relative to the fellow eye. It is assessed, as you all know, by the swinging flashlight test. The normal pupillary response is characterized by equal constriction of pupils in both eyes when the light stimulus is applied to each eye individually, with no dilation when the light swings from one eye to the other. When the patient has a RAPD, pupil constricts in both eyes when light shines into the normal eye, but there is dilation of pupil in both eyes when the light stimulus is rapidly transferred from the normal eye to the pathologic eye. So RAPD is a difference in pupillary light reaction between the two eyes and gives you objective evidence of efferent pupillary dysfunction. RAPD is most often seen in unilateral or asymmetric bilateral lesions affecting the retina and the prechiasmal optic nerve, but they can also be seen in lesions affecting the visual pathway in front of the lateral geniculate body. If you find an RAPD, what you know is that this is not coming from other ocular conditions, say, for example, cataract or corneal edema. RAPD is also useful in localizing the site of vision loss in patients with unilateral vision loss. For example, in our patient, this helps me to localize a site of vision loss as being either in the retina or the prechiasmal optic nerve.
Thank you, Dr. Simon. That really helps me, because from a neurology perspective, we're all about localizing the lesion, and the optic nerve is similar in many ways. So the RAPD in this instance is helping us localize the lesion to either involving the retina or the prechiasmal optic nerve? We know that's what we're dealing with here. And the question is, what's the etiology? And we've got some additional information in that history that's pointing us in a particular direction. So now they do an optical coherence tomography, or an OCT, and fundus fluorescein angiogram, abbreviated to FFA, which demonstrate severely decreased arterial filling and non-distinct retinal layers in both eyes. Their initial blood tests returned in the emergency department setting, and their CRP, or C-reactive protein, was 29.8, and ESR, erythrocyte sedimentation rate, was 59, and they have platelets of 362 on presentation. So, Dr. Simon, I have to say, some things in ophthalmology always make me pause and think and then look it up. And some of these tests are among those categories. Could you please explain what an OCT and an FFA is for a generalist audience? How these tests help you with your diagnostic formulation, and what do you think's next for this patient?
Okay, so optical coherence tomography is a non-invasive imaging modality that is very widely used to evaluate diseases affecting the optic nerve, the macula, and retina. It is quick and easy to perform, so it can be done within a few minutes and does not use a dye. OCT is analogous to ultrasound imaging, but it uses light instead of sound. So it is an optical imaging modality. It utilizes a concept called interferometry to provide high-resolution cross-sectional tomographic images of the retina. It can provide cross-sectional images of the retina on a micron scale, and this is in situ and in real time. In other words, it can function as an optical biopsy of the retina and provide structural information about the layers of the retina. It can also give information about the thickness of the macula, thickness of the ganglion cell complex, and retinal nerve fiber layer thickness. It gives useful information about optic disc morphology and peripapillary retinal nerve fiber layer thickening. This makes it very useful in monitoring glaucoma and other optic neuropathies. One thing to remember is that the media must be clear in order to perform an OCT. So it is very difficult to get a good quality OCT scan in a patient with advanced cataract or an eye with dense vitreous hemorrhage. Fundus fluorescein angiogram, on the other hand, is an invasive modality for imaging the disc, retina, and the choroid. The pupils need to be dilated. It also entails injecting fluorescein dye into the antecubital vein. And thereafter, serial fundus photographs are taken using a special fundus camera. It takes about 20 to 30 minutes to perform an FFA. Abnormalities are detected on FFA as hyperfluorescence or hypofluorescence. It is particularly useful in evaluating vascular abnormalities affecting the retina and the macula. FFA is also useful in diagnosing choroidal ischemia. So coming back to our patient, I'm presuming that the patient's left fundus examination is unremarkable and the vision is normal at this stage, Stephen?
Yes.
So the OCT confirms the diagnosis of central retinal artery occlusion by demonstrating loss of normal retinal architecture in the right eye. In central retinal artery occlusion, OCT will also show hyperreflectivity of the inner layers of the retina due to retinal edema. But there are similar retinal findings on OCT in the left eye, and I'm very concerned about an evolving central retinal artery occlusion in the left eye. When we look at the FFA findings, it shows decreased arterial filling, not only in the right eye with central retinal artery occlusion, but there are similar findings in the left eye. So delay in arterial filling is consistent with the diagnosis of central retinal artery occlusion. But I'm concerned at this stage that this patient has an impending or evolving central retinal artery occlusion in the left eye. If the choroidal filling time is also delayed in this patient, that's useful information, because what it tells us is that in addition to central retinal artery occlusion, this patient also highly likely has giant cell arteritis related stenosis or occlusion of the ophthalmic artery or internal carotid artery on the ipsilateral side.
Thank you. So giant cell arteritis was suspected, as has been discussed, and the diagnosis was later confirmed with a temporal artery biopsy. However, that result was not available at this time. The patient was treated with 1 gram of IV methylprednisolone daily for 3 days. However, after 2 doses of the IV methylprednisolone, there was a deterioration. So the best corrected visual acuity had declined to light perception in the right eye and counting fingers in the left eye. Examination showed a development of a new central retinal artery occlusion in the left eye despite appropriate medical therapy. Dr. Simon, this is clearly a grave position with respect to this patient's vision. How commonly does this occur in GCA, and what are the risk factors for a progressive course, and what do you think will happen now for this patient?
So this development is very unfortunate for the patient, because it's no longer a unilateral process, but it is a progressive and bilateral process. Progressive visual loss in giant cell arteritis can occur in up to 27.5% of eyes despite high-dose IV methylprednisolone. We also know that progressive vision loss usually occurs within 1 week of commencing IVMP. The possible reasons for progressive visual loss despite high-dose corticosteroid in GCA patient could be that the dose is still not good enough. It could be that we have a highly aggressive disease in which the rate at which the inflammation is getting controlled is not good enough. Or it could be due to inflammation being resistant to the glucocorticoids. Or the other possibility to consider is that this could be due to advanced luminal stenosis and thrombosis. In our patient, the vision loss is progressing despite IVMP, which was given promptly. And in this case, glucocorticoid-resistant GCA needs to be considered, especially if the inflammatory markers are persistent and not showing a downward trend.
In view of contralateral spread of this inflammatory process, the treating team have prolonged the course of methylprednisolone to 5 days now and initiated a therapy known as salvage tocilizumab therapy. Subcutaneous tocilizumab was delivered following 3 doses of the intravenous methylprednisolone, and the patient's best corrected visual acuity improved from hand movements in right eye and 6 on 12 in the left eye within 48 hours of tocilizumab treatment. At 4-month follow-up, the best corrected visual acuity had improved further to 6 on 9 in the left eye and remained stable at hand movements in the right eye. Additionally, his visual field index had improved by 9%. So maybe, Dr. Simon, in view of this, could you maybe please explain what tocilizumab is, how it worked, and I guess maybe what was potentially the rationale behind the treating team's decision to introduce this therapy into this patient?
In recent years, there has been significant developments in working out the immunopathogenesis of giant cell arteritis. We know that giant cell arteritis is characterized by chronic granulomatous inflammation and affects the large and medium-sized arteries. And the arteries have adventitia, media, and intima. In GCA, following an unknown trigger, there is breakdown of immune privilege in the adventitia, where vascular dendritic cells recruit CD4 T cells. And this sets off a complex inflammatory cascade. The end result of vascular inflammation is luminal occlusion and ischemia, as we all know. Interleukin-6 is significantly elevated in serum of untreated giant cell arteritis patients, And some studies have shown that it is a more sensitive marker of disease activity than ESR. Interleukin 6 is a pro-inflammatory multifunctional cytokine produced by a variety of cells, including T cells, B cells, monocytes, and endothelial cells. Interleukin 6 induces T cell activation, B cell differentiation, and also acute phase protein production. So, where does tocilizumab fit into the picture? Tocilizumab is a biologic disease-modifying drug. It is a recombinant humanized anti-interleukin 6 receptor monoclonal antibody. Tocilizumab binds to the interleukin 6 receptor and prevents interleukin 6 from binding to its receptor. Tocilizumab controls inflammation by inhibiting interleukin 6 signal transduction. Blocking interleukin 6 may halt the differentiation of CD4 cells into the T helper 17 cells and thereby reduce vascular inflammation.
I might just add, I think a few of our listeners would be familiar with tocilizumab, particularly in the setting of its use as a steroid-sparing agent, and also in other settings such as treatment in the cytokine release syndrome that we see with a few kind of hematological and cancer-related treatments. I'd be interested, Dr. Simon, so we know tocilizumab, chiefly its function has been, at least in part, driven by the JACTA trial as a steroid-sparing agent. What was your team's rationale for starting it as an acute salvage therapy? Was there any evidence that you had used previously to drive this decision, or was it kind of a spontaneous move? I'd be interested to hear.
So we didn't have a robust data to back use of tocilizumab in this setting. We came across 3 case reports that proved to be beneficial in either improving or stabilizing vision loss in patients with glucocorticoid resistant progressive giant cell arteritis related visual loss. So that was a rationale for trialing tocilizumab in our patient.
So thank you for that discussion, Brandon and Dr. Simon. I think I've certainly learned from it. We as physicians need to be aware of the ophthalmic manifestations of systemic disorders. And as evidenced by this case, giant cell arteritis can be sight-threatening, bilaterally so, and prompt treatment and a structured approach to investigation is required. And sometimes very specialized treatments, including tocilizumab, are required. So just to wrap up the case for everyone, I'd be really interested both of your perspectives on the key learning points from this case. So perhaps, Brandon, you could give us some of your key thoughts, and then Dr. Simon, if you could give us your final thoughts on the case, that'd be great. Thank you.
Great. So I think one of the first learning points is the importance of early diagnosis and treatment in conditions like giant cell arteritis. This case really underscores the critical nature of timely diagnosis and aggressive treatment in these conditions, the worst possible outcome being progression to legal blindness in this setting. The value of tocilizumab in refractory cases was certainly highlighted here, and I think that in turn speaks volumes to the fact that we talk about an evidence hierarchy where the gold standard is randomized controlled trials in many settings. However, I think in this sort of setting, value is lended by case reports, and so the evidence hierarchy needs to start somewhere. And so where possible, publication of case reports should still be encouraged where they have the possibility to lend alternative treatment algorithms and considerations for patients in the future.
Thanks, Brandon. For me, the key points from this case was 1, detailed history taking and clinical acumen are still key elements in establishing a timely diagnosis of giant cell arteritis. 2nd, Amaurosis fugax warrants urgent investigations and warrants referral to an ophthalmologist. 3rd, high index of suspicion for giant cell arteritis and prompt referral of giant cell arteritis suspects will ensure best outcome for our patients. 5th, progressive visual loss and elevated inflammatory markers should alert the clinician to glucocorticoid-resistant giant cell arteritis. Next, multidisciplinary management is absolutely vital to reduce morbidity and mortality. And finally, Targeted biologic agents may open up new treatment approaches for giant arthritis in the future, particularly in patients with progressive visual loss despite IVMP use. So those were the key learning points from this case for me.
Thank you very much, Dr. Simon. So that concludes our discussion of this case. So for more details, the full article's title is The Role of Tocilizumab in Glucocorticoid-Resistant Giant Cell Arteritis, a case series and literature review. This was published in the Journal of Neuro-Ophthalmology in 2023, with the first author, Dr. Brendan Stretton, and senior author, Dr. Sumu Simon, who have joined us today. We really appreciate your help learning from this patient's case. So thank you again.
Thanks also to Dr. Stephen Bacchi for driving this case report podcast. Feel free to submit any ideas for cases to unpack or journal articles to dissect by writing to podcast@racp.edu.au. I'm thrilled to have more member-created content like this and the previous Journal Club and IMJ On Air episodes. It's always been a mission of Pomegranate Health to create a sense of collegiality among RACP members by letting you hear what other specialists are up to. Please let your colleagues know about the show, or leave a review at your favourite podcasting platform so that other people can find us. There are lots of apps to choose from, though the key players are Apple Podcasts, Spotify, Castbox, Podcast Addict, Google Podcasts, Overcast and Pocket Casts. Or the late adopters can subscribe to our email alerts list, which will let you know anytime a new episode is published. This podcast was produced on the lands of the Gadigal clan of the Eora Nation. The RACP has a commitment to advancing the health and education of Aboriginal, Torres Strait Islander and Māori people. I'm McEwin. Thanks for listening.